I can see there is multiple erythematous rashes over the both legs on the extensor surface, extending from the thighs, legs, and even the foot on the first pictures of various size and shapes. And the second picture, I could see there is a non-blanchable rash as evident by a glass test or the tumbler test, which is non-blanchable rash.
Very good. So, what history will you ask this patient?
So I would like to know if the child is having the fever currently, and if the child had no fever currently, I would ask if the child has any recent fever, like a few days or few weeks back, or if there is any bleeding from a mucosal surface like gum bleed or the nose bleed, or any other uh, bleeding from the body sides. And I would ask to no, I would like to know if how is the urine output, and is it less or not. And I would ask if there is if the child is having any altered sensorium or any seizures, or how sick the child is.
Okay.
And I would
Okay.
also ask the
And
if any family history of bleeding disorder.
okay. Anything in and what will you see in the physical examination?
So on the physical examination, I would start taking note of the vitals, uh, uh, the BP, pulse rate, saturations, and then I would like to examine the child, uh, uh, especially the neurological examinations, uh, to see if there is any signs of meningitis, which is quite important to note. And I would look for if there is any hepatosplenomegaly or lymphadenopathy, and I look
Why will
for.
you see hepatosplenomegaly and lymphadenopathy?
So I would like to know if the child has these manifestations because of the malignancies,
Very
such
good.
as acute leukemia.
Okay. So what are the differentials if for this child? If this child is a well child, and if this child is a sick child, give me if consider first this is a well child, then what's your differential?
If this is a well child, then my first differential diagnosis would be idiopathic thrombocytopenia purpura (ITP), and
Very
and
good.
then if that's if and then the other differential diagnosis is that if the child is having if the child is sick and having abdominal pain, then I would put the hanoxysculum purpura as the cause of this purpura, which is a form of vasculitis. And if the child is sick, having fever with in shock, or having features of meningism, then I would put meningococcimia as a differential diagnosis. If the child is sick and shock, and then differential diagnosis could be DIC, disseminated intravascular coagulations. And then if it is a case of long prolonged history with recurrent fever, and then the thinking of acute leukemia, I would put the another differential diagnosis for this.
You even ask for urine output. Anything specific with that
Uh,
for the diagnosis?
yeah, for the diagnosis, if this is because of the vasculitis, most primarily the henoxysculum purpura, leading to the nephritis, or any form of systemic lupus erythematosus, or any connectivity disorders leading to nephritis, would lead to renal oliguria.
Okay. So how will considering this is ITP, how will you manage this case?
Uh, with the ITP, I would first like to know the clinical assessment of the child. If there is just only the depending upon the severity of the bleed, uh, then the management would differ. If there is only the skin bleed, I mean only with the petica and purpura, no obvious mucosal bleeding, the observation would be wait and watch, and educate the parents and the child to avoid
Will you investigate this child first?
yes, of course. So yeah, to confirm the diagnosis of ITP, most importantly is that on full blood count, the platelet will be low, whereas the other cell counts will be normal, and
Mhm.
the peripheral body smears will be normal without any blast cells. And
Okay.
on, on, on examinations,
If
there
there is
won't be.
also associated anemia and leukopenia, what will you think of?
Yeah, in that line, the pancytopenia, the differential diagnosis would be either leukemia or
Okay,
aplastic anemia.
very good. And if it is an autoimmune condition, only anemia and thrombocytopenia, what would you think of? Autoimmune thrombocytopenia and anemia. Ivan
So I
syndrome,
would,
have you heard?
yeah,
Ivan syndrome. Okay,
yeah, I would think of
then,
Ivan syndrome. Yeah.
yeah. Okay. What is the role of bone marrow biopsy in this patient?
The role of bone marrow biopsy,
I'm finished, but you can continue.
if it is a idiopathic thrombocytopenia, I would not go for bone marrow aspirations. But if
Okay.
any of
Which
the cell
condition?
lines,
Yeah.
yeah,
Which
if any of
conditions will you think of bone marrow in this?
So, if there is any feature suggestive of malignancies evident by cytopenia or evident by clinical examinations with hepatosplenomegaly or lymphadenopathy, or
Very
if
good.
there is a chronic features of ITP, I would go for bone marrow aspirations to rule out malignancy.
Very, very, very. And which conditions you said in mild bleed you not do anything. Okay, so what will you do in significant bleeding and moderate bleeding of ITP? And how do you define significant and moderate bleeding of ITP?
The significant bleeding in ITP would be a large amount of bleed from any mucosal surface, uh, leading to symptomatic leading to symptoms as well as the lab parameters such as hemoglobin being low and clinically child is unstable. Then we'd go symptomatic management, maintaining the airway, breathing circulations and vitals, and the blood transfusions, and also we'd go for treatment with IVIG.
Okay, and
and,
what else
and
options, other options you have?
yeah, and then the other options would be the steroids to give to the child in the
Very
higher
good.
dose initially, followed by tapering dose and stopping as the platelets
So you're
comes
telling
to normal level.
significant bleeding. Moderate bleeding, how do you define moderate bleeding in ITP?
The moderate bleeding in ITP would be the child will be stable without symptoms,
Hmm.
and then there won't be bleeding as to so as to cause symptoms to the child.
Okay. When will you involve the will you involve your consultant and when will you involve a hematology consultant?
So I would involve the consultant in this case, as well as the hemato-oncologist if there is if there is feature suggestive of malignancies, or if there is any doubt in diagnosis.
Okay. 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 And what will you advise the mother?
So I'll advise the mother that I would advise the mother the natural history of this illness, that most of the ITP they resolve by 6 months of age, and few of them they can persist beyond 6 months also. If there is only petechiae and purpura in the skins without any major bleed, uh, uh, that the child can be managed at home. And then the few things that she has to avoid is the contact sports,
Very good.
of the because of the because of the contact sport, then she could have hematoma on the muscles.
Mhm.
Then she needs a follow-up in the GP
Hmm.
or in the pediatric OPD.
How will you
Then
follow up? Like how frequently? Now this child you have discharged with a platelet count of 30,000. How frequently will you monitor the complete blood count? And will you stop monitoring the complete blood count?
Exactly, I don't know exactly with the what is the
Okay, no,
guideline.
no.
Mm,
Now this is a girl, 6-year-old girl.
mm.
Any chance if she becomes pregnant? Any chances of a baby become having any problem?
The baby can also have the thrombocyte.
Baby, even the
Yeah,
baby can have
yeah, yeah,
thrombocytopenia.
yeah.
Yeah.
As well.
How do you define chronic ITP?
The chronic ITP is the if the platelet count remains low, less than
Hmm.
150,000, lasting for beyond 6 months, it is chronic ITP.
Beyond 1 year. Beyond 1 year. So for chronic ITP, any extra investigations you'll do?
So in that situations, then we'd go for anti-DS-DNA.
Okay, very good.
Basically, we are trying to find if there is any autoimmune
Very
systemic conditions, and we'll go for the bone marrow as I said, and then we can go for the HIB studies as well, depending upon the situations.
yeah. That's it, Dr. Amit. Thank you. Very nicely done.
You took
Thank you so
10
much.
minutes with me.
but Dr. Noor, I thought we don't know what the examiners are going to
Yeah,
ask.
yeah.
So
Let
might
them
as well we
ask
cover
me.
all
Any of
questions.
the questions can. Yeah, yeah. Good. It was.
It was very nice.
Wait. Before giving the feedback, I just
Yeah.
want to ask: did he cover anything, or you feel that if there is lacking, I will ask the other candidate to do again? What do you
This
think?
will very minute things,
Huh?
I think, here or there, which is extremely pardonable, which he has missed, I feel.
Okay, but for the next one, we will do it exactly for 6 minutes and see. Okay.
Acha, okay, fine.
Wait, just wait.
Who is the next candidate?
Okay, you can start 6 minutes from now.
Okay,
Please
so today I
explain
saw
your
the video of 6-year-old girl. I will say about whether well looking or not, any specific surrounding and any distress. And then I can see on skin examination, there is erythematous rashes, purpuric and petechial rashes over both the lower limbs. And I don't know, on the lateral side, some pigmentation or same rash, which is visible like on the near to the right knee. And also there is a glass test is done where it is non-blanchable rash. It is.
Okay, so please can you tell me what will you ask in the history?
Yeah, I would like to take history about the onset, progress of the disease, and any involvement of the anywhere in the upper part of the body, and also any bleeding from any side, mucosal bleeding. Any history of associated fever at present and other symptoms associated, and any previous history of any respiratory infection, and yeah, any lumps and bumps, anything they have noticed, and any history of travel, and any history of this history I will take.
Okay. What will you
And
examine?
also,
Yeah.
Also I would like to check if the child has any features of like neurological involvement in the form of like how is the consciousness, I will ask, and any seizure episodes in the history. And in examination, I would like to do the head-to-toe examination, including the vitals, the heart rate, capillary refilling time, blood pressure for this child, and also complete CNS examination, and in general examination regarding any pallor, any lymphadenopathy, and any hepatosplenomegaly in the abdominal examination.
Okay, so what are your differentials for this child?
Yeah, my differential diagnosis is it could be depends on if the child is well looking or ill looking. If it is well looking, then I would like to put the possibility of ITP and maybe HSP to rule out, and other Yeah, this is if it is well looking. If it is ill looking, first possibility is meningococcimia, or maybe any malignancy, or it could be any infection like malaria or any other viral infection which can have thrombocytopenia.
Okay. And okay, fine. So considering this is ITP, should I change the diagnosis, Dr. Noor, or should I continue with ITP? Okay, if this is ITP, how will you manage it?
Because it's a non-blanchable rash, the first possibility is meningococcimia.
It's a well child.
Okay.
Can
Okay,
also
so
make
suppose it's
HSP
ITP.
otherwise.
Okay, no problem.
Make it HSP otherwise better.
No, I'll making meningococcimia. I was thinking of.
Okay, no problem. Anything.
If this is
as you like.
meningococcimia, how will you go ahead?
Okay, so if it is meningococcimia, then I would take it after examination and involving my consultant. I would like to check for the airway, breathing, and circulation if it's stabilized or not. And once they cannulate, they'll send all the investigations for complete blood count, CBC, CRP, blood cultures, and also for the PCRs, meningococcimia, and yeah. And if needed, a lumbar puncture if
Any
child is
bedside
stable only.
immediate tests that you need to do bedside?
Immediate test to bedside is fundoscopy we can do to look for any raised ICP features. And already glass test it's been done. And yeah.
Glucose will you do? BSL, RBS, sorry, random blood sugar.
Yeah. All the electrolytes, urea, creatinine, LFT, blood sugar, everything to be checked for any sick child. Yeah.
Okay. Then after that, how will you proceed?
Yeah, even urine routine should be done. And after that, in the management, airway, breathing, circulation, and IV antibiotics should be started immediately. IV ceftriaxone. And and child should be shifted to the, if needed, to the PICU.
If the child is considered to be less than 3 months, then what will you add? Less than 3 months.
Okay, then ampicillin should be added.
Okay, very good. Fine.
Ampicillin should be added, yeah. And yes, if PICU, the child should be shifted to the PICU for the monitoring.
Okay. When will you perform the lumbar puncture in this child? Will you perform?
First, after initial investigation, looking after the any like thrombocytopenia, the level we should check. Also, the child sensorium and fundoscopy. If it is child is unconscious and sick, will not go for the lumbar puncture.
Very good. Okay, these are the what are the other contraindications for lumbar puncture?
6 minutes, but you can go.
If other contraindication is like any local infection over the area where we are going to do the LP. Other is like sick child thrombocytopenia and
how much thrombocytopenia should you avoid?
50,000 below.
40,000 as per the red book. Okay.
Okay.
And rest you said okay, fine. Now, how if this is meningococcemia, what is your length of antibiotic course going to be there?
Yeah, meningococcemia, at least 10 to 14 days of antibiotic, and also the prophylaxis should be given to the healthcare personnel who is exposed and the near family members. Yeah.
7 days. Meningococcemia 7 days, 10 days it's hemophilus influenza.
Okay.
Okay. Very good. And how you were telling about the healthcare worker giving?
Yeah, prophylaxis to the healthcare worker and also to the near relatives or who got exposed to the child.
What prophylaxis will you give to the healthcare worker?
I think ciprofloxacin.
Yeah, single dose ciprofloxacin. And if this is hemophilus influenza, 10 days antibiotic, what will you give as prophylaxis?
Yeah, in hemophilus influenza, rifampicin.
Very good. Yeah. How will you follow up this child?
Yeah, this child should be followed up regularly. for mainly to look for the progress of this illness, and also hearing test should be done. Hearing.
When should the hearing test be done?
Exactly, I don't know.
At
Maybe
6
month.
weeks after discharge.
Yeah.
Besides the hearing, what other complications in meningococcal disease you will see?
Okay. Other neurological deficit.
Okay, very good. And orthopedic complications, if there is
yeah,
bone
they can
involvement.
have. Yeah, they can have
and skin
osteomyelitis.
necrosis.
Yeah.
If there is skin. Okay, in the acute management, besides the antibiotic, what other things are you going to keep in your mind? Other aspects of your management that you will be thinking of?
Yeah, other than antibiotic, it is mainly for treatment of the raised ICP should be taken care.
Very
then
good.
also for the urine urine output and monitoring is
should be
important
taken
in
care of.
children. Yeah.
Okay.
And
what
other
else?
than that is nutritional part to be taken care of for the child. And on
Metabolic
electrolyte
part.
imbalance, yeah,
Yeah,
electrolyte should be checked, and blood sugar electrolyte should be checked and monitored.
Okay. Okay. And fine, I think. I don't think so. Other things they will not ask me on this. The dexamethasone is one thing that you.
No, good. You are covering everything because we don't know.
I'm asking more than what is required, but I think so. Just it will make you more prepared for the exam. Okay, when will you restrict fluid in this case? This is a meningitis case. When will you restrict fluid?
Yeah, restriction of the fluid. Sometimes for the raised ICP also.
Very good. And
if a child is going with ADH. And also if they are having multi-organ like renal failure, if it is going there.
Oh, very good. If this meningococcimia is in the shock stage, how will you give the boluses? Yeah,
we'll start with the 20 ml per kg bolus.
What will you use for 20 ml?
Sorry, normal saline. Normal saline 20 ml per kg, and we'll put, if possible, central CVP line should be there, and so that we can monitor. And but we can go up to 60 ml per kg with monitoring. And then inotropes would be started. We'll start with the dopamine and adrenaline, noradrenaline.
Adrenaline and noradrenaline is written in the places. And second and third, instead of normal saline, you can even use any other thing you can use instead of normal saline. Albumin, 4.5% albumin also you can use for the second and third bolus in this shock, meningococcemia shock. Okay. Okay. Now let the duration of meningococcal, you told me 7 days. Haemophilus influenza, I told you 10 days. Pneumococcus, how many days?
Pneumococcus, 7 to 14 days. I don't know.
14 days. And gram negative? 21 days.
21 days, yeah.
I think that's it. This steroid is one thing. I think dexamethasone, well, just before the antibiotic, you have to give that also 0.15 mg. That just was. Yeah,
child in shock with fluid not responding will go to 1 dose of dex. We can go for hydrocon.
Yeah. Okay, finished or still you have
questions? That's enough, I think now.
Extra, you asked questions for 3 minutes. I kept the stopwatch. Okay, no problem. So now you will give first what feedback to ITP?
First. Okay. I'll just tell for the history and physical examination and DDs, there will be a general. There's going to be a single thing, that's going to be that how they ask onset, duration, progress. Both of them ask. Reading from any other site. What Dr. Sridevi extra asked was history of a recent URTI, because that is important for ITP. History of bone pains, history of swelling anywhere in the body or tummy distension, history of fever, decreased feeding, lethargy, or this is for a small child. Both of them did not ask history of drug intake. And even non-accidental injury should be kept, in our mind. So a social history I will take. Means this does not look like a non-accident injury, but if there is only bruises that are seen and no fatigue, then at that point of time, non-accidental injury should be kept in mind. Physical examination, both of them covered all points: vitals, seeing the sensorium, whether the child is well, unwell, whether there is pallor, how is the extent of the rash, lymphadenopathy, HS megaly, complete CNS examination, both of them said. About the DDs that they gave, the DDs which did not mention, I will just tell you that drug-induced thrombocytopenia was not mentioned by both of them, and non-accidental injury. Rest, the other ones like ITP, the hematological one, ITP, leukemia, lymphoma, aplastic anemia, the vasculitic one, HSP, then the bad ones like the meningococcimia, sepsis, DIC, was all mentioned. I was even asking Dr. Amit about urine output that he asked. I thought he had hemolytic uremic syndrome in his mind. That's why he's asking. So even that could be one of the causes, which can cause this kind of a problem. Then I'll just go to the ITP. Then I'll go to meningococcemia. ITP, the things which I asked him, when will the bone marrow be done? So bone marrow, as he rightly mentioned, if there is HS megaly, if there is lymphadenopathy, if there is pallor, if there is limping severe, and he told if the cell lines, other cell lines are also reduced, that time we should do a bone marrow aspiration. I asked him what is significant bleed. Significant bleed, he told me major bleed from the mucosal surfaces, not from the mucus, from the GI, in the intracranial, or if there is uncontrolled epistaxis also. And moderate bleed is prolonged mucosal bleeding. So in both of them, IVIG and prednisolone have a role. I don't think so we have to remember doses and everything because that will be too tedious. Then I asked him, when will you involve a hematologist? Every new case of ITP, you should involve a hematologist. Or if they are going on for any dental procedures, operations, or essential operations, at that point of time, we should involve a hematologist. Okay. When I asked him, how will you advise, he gave properly very good advice that it will resolve in 6 months. The treatment has very good, it's favorable, and avoid contact sports. That was the right thing. Then I asked him, how will you monitor this? And he said, I will keep on monitoring. So monitoring will be done monthly. The complete blood count needs to be done monthly. And we can stop doing once the platelet count has reached above 1 lakh or the child is asymptomatic, and the child is asymptomatic, both more than 1 lakh and asymptomatic. Then that time I asked him whether this child has any mother, as a mother, will the child have a problem? So yeah, pregnant mother with ITP, the child can have a risk of thrombocytopenia, he rightly mentioned. Chronic ITP, I asked the definition, it was more than 1 year. Acute is 0 to 3 months. Then persistence is 3 to 12 months. Chronic is more than 12 months. That was rightly said by him. And avoid contact sport, avoid NSAIDs. And he said, whenever there's chronic ITP, see for autoimmune, autoimmune and immune deficiencies. Hello? Yeah, I think I'm audible.
We are listening, go ahead.
Immune deficiencies and autoimmune. So autoimmune conditions, he rightly said, I will go in for the ANA, anti-DSGNA. We can even say APLA, that is anti-cardiolipin, anti-phospholipid antibody. And for immune deficiencies, we can see for HIV, IgG, IG. That is only if we are asked. I don't think so they're going to ask so much. I'm just telling. And chronic ITP, once again, the treatment modalities are steroids, monoclonal antibodies, and splenectomy. Okay, so this was about ITP. About meningococcemia, I almost started telling everything what she was missing in between. That when immediately ABC, first will be ABC, vascular access, immediately collect the blood for CBC, blood culture, CRP, glucose, all the electrolytes. Meningococcal, pneumococcal, PCR should be sent. That is one thing I think she missed out. And blood gas, I think I don't remember. I must have missed out if she said that. Okay. And after that, immediately the child
One
will
minute.
get up.
She did not say blood gas. I wrote here. Yeah, she did
She
not
didn't
say
say
blood
blood.
gas.
And that's yeah, I'm seeing. Very nice. So
Blood
and
gas, lactate, all those things are important, right?
lactate, yeah. That was just not an PCR was that's the diagnostic thing. So that was just missed out. And the thing is, going for a lumbar puncture and her contraindications were right, that if the child is in shock, her GCS is less than 9, is in seizures, is having a focal neurological deficit, having a papilledema, having a local infection, having a platelet count less than 40, having a coagulopathy, you should be avoiding. And giving antibiotics as the less than the drug of choice is cefotaxime or ceftriaxone, full dose that needs to be given. Okay, and if it is less than 3 months, add amoxicillin. Just one question I wanted to even ask her: if the hepatic enzymes are deranged, anything that you will add, Dr. Sridevi? Dr. Sridevi is here.
Yes.
If the hepatic enzymes are deranged, this is a small baby, for example, anything else that you would like to add in the antibiotic, in the medicine? Dr. Neely is putting the answers. Acyclovir, because you should think of HSP, you know, if it is especially a neonate, raised ALT, raised AST, this kind of a picture, you should have HSP in my mind, okay? And subsequent management, she told rest everything was almost covered, you know. Length of antibiotic course I mentioned 7, 10, 14, 21. Just remember that much. And I made a very pathetic mnemonic, so if anybody wants to remember, I think the Indian crowd will remember it. There was this film called as Main Hoon Na, so I made it Main Hoon Pagal Na, like meningococcus, hemophilus, pneumococcus, and negative, gram negative. So Main Hoon Pagal Na, you can remember 7, 10, 14, 21.
Can you again repeat it, please?
Meningococcus, hemophilus, P is pneumococcus, and Na, N is negative, gram negative.
Gram negative. So 7.
7, 10, 14, 21.
Okay.
We always say 7 to 10, 10 to 14, 14 to 21. So like that.
Yeah. 7, 10, 14, 21. Yeah. Nice.
So, and she rightly mentioned about the profile, close contact prophylaxis, ciprofloxacin for meningococcal, and hemophilus will be rifampicin. And rest formally hearing test on follow-up, they will, this is some questions they will always ask: how will you follow up? So 6 weeks you should do hearing test. And if this child had some other complications like a CNS complication, then the focal neurological deficit, ortho complications, then look for the ortho complications and follow up if there is bone involvement, and skin necrosis if there was a skin involvement. Okay, there was one question they can even ask you: when will you refer, Dr. Sridevi, this child to immunology? I missed that. Or immunology, when will you refer this?
In immunology.
Immunology. This is a meningococcal disease. Okay, meningococcal infection proved.
Yeah, if it is recurrent infection which is going on.
More than one episode, especially if the child has been vaccinated. Okay.
Yeah, okay.
And or if there's a family history of meningococcal disease or immune deficiency, then at that point. Yeah. So that's it, I think, Dr. Noor.
And the source is Red Book in both the cases.
Red book and just meningococcal, I had put those a few extra points from here and there, I think. Other aspects, like how to, other aspects if they say in management besides the antibiotics, so we need to manage the metabolic complications. These things they can ask us, you know, like hypoglycemia, acidosis, hypocalcemia, everything has to be managed. And if there are seizures, then we have to manage the seizures. If there is shock, we need to manage the shock. If there is raised ICT, we need to manage the raised ICT.
Okay, mashallah, it was nice presentation. Our role player and presenters both are very good. All the best for you.
Thank you,
Dr.
Dr.
Noor, I have one question.
1 minute, even in the exam, I don't think we will be able to answer 100%. At least the way they covered, I think it was good. And we know in that time we are just doing extra so that we will be ready for everything, anything they ask. Or maybe now, I don't know, I saw today some non-accidental injury case has come in the clinical, because now it is with patient, they are asking whatever they want anywhere. So it's not like before we expect that the neonates will not come in clinical, that this will not come in clinical, because now there is no patients, any age child can come in the clinical. This is the thing. So better to be prepared. That's it. Okay, Dr. Yasser, you can go ahead.
Yeah, I have some reservation regarding this differential. We have to present the differential. We have first, second, third. Is it justified? We justify them at the same time. Just because this is the question of the examiner, they will ask why you think this one, why you think this one, why you think this one. We can give 4 differential.
Sometimes we can, for example, even differentials we can justify in the same breath. Even our investigations we can justify. Like I'll do CBC to see for thrombocytopenia.
No, if he asks why you are doing this one,
not
you
necessary for them to ask. We can say they will not take this in a wrong sense. Hope so.
See, here we told take it as the sick child and the normal child. But in the video, what they show, it will be clear whether the child is normal, whether they are going towards ITP and or they are going towards meningococcimia. They will give you all the readings and signs and everything, I believe.
And second, Dr. Munazza, from where you the reference for steroid in meningococcal, only the H influenza is the bacteria.
Dexamethasone is
Dexamethasone is only for this one H influenza, just causing the hearing deafness. Others, no bacteria can cause hearing deafness.
The Red Book has given overall for this meningitis, in case of their lumbar puncture showing a WBC, which is, I just tell you one thing, a WBC of more than 1000. It's a purulent CSF and a raised protein in the CSF and a bacteria on gram stain. Irrespective of the report, they have written that we can start within 12 hours of the antibiotic. The Red Book says that.
Okay, I will check it, because up to my knowledge, it's H influenza is the one. But that causing hearing deafness. And
but in
others,
Red Book, it's
usually if they associated with shock, there is a role of hydrocortisone.
Hydrocortisone, if it is not responding, to inotropes, then the hydrocortisone will come. Only one dose, 100 milligram.
Yeah, one dose only. Yes.
Excuse me, if this
for meningitis, so that they can be better penetrance of the antibiotics also.
Excuse me, if this patient meningococcemia, there is one complication, Waterhouse Friderichsen. If adrenal deficiency, we have to give hydrocortisone, not only one dose.
Yeah, that is
complication.
Yes, if there is adrenal deficiency.
Yeah, that syndrome is called as something. I'm remembering.
So we have to give hydrocortisone, not only one dose.
Waterhouse Friderichsen.
Yeah. This is like Addison crisis. So we have to do it. But there are other parameters, just like anemia, hypotension, not responding to anything. This metabolic acidosis, hyperkalemia, this hyponatremia. So these are the other parameters on the behalf of we can decide. But okay, thank you.
I think in any
thank you for your input and this Waterhouse Frederick, because even the RBS that we said need to be mentioned and all that, it puts all that into place. Thank you.
I think, Dr. Muslim, we can give dexamethasone in any bacterial, but viral there is no role.
No.
To say it, yeah.
That's why the criteria for the CSF is such that it puts in bacteria and bacterial meningitis in place.
Because it causes adhesion, not only hearing loss. If in bacteria there is purulent meningitis, so they can cause adhesion. To prevent that adhesion, we give dexamethasone also, not for only hearing loss.
Dr. Noor, I'll have to rush to the hospital. Is it fine if I leave the meeting?
Okay, yeah, please.
I'm sorry, huh? Thank you.
Yeah, no problem. 2 minutes, and then we will just go through our case, okay?